Good morning and good afternoon, everyone, wherever you may be throughout Australia, New Zealand and parts of Asia. My name's Gary Morrison. I'm part of the Management Committee of the Shine a Light Group. Before I start, I'd like to do a brief welcome to country. In recognising Aboriginal and Torres Strait Islander people's spiritual and cultural connection to country and our continuing commitment to reconciliation, I would like to commence the meeting by acknowledging the First Peoples and the traditional owners and custodians of the country wherever we may be. We respectfully acknowledge our elders, past and present, and remember that they have passed on their wisdom to us in various ways. Let us hold this in trust and as we work and serve our communities. Again, welcome. This is the very first of our webinar series for 2022. Firstly, I'd like to apologise for our false start going back a couple of weeks ago. We had technical issues with Zoom, but the upside of all of that is that we've managed to be able to attain 40 to 50 new registrants, and I'd like to welcome them all. Our webinar series this year is going to consist of 5 webinars, which we will space throughout 2022. The series is going to have themes of erectile dysfunction, exercise, nutrition and sexual intimacy, urination troubles and radiation therapy. And the last one will be Prostate Cancer 101, current and future treatments. In bringing these themes together, we were thinking hard about what would be the best topic to start the whole series. And given what we've all been through over the past 2.5 to 3 years with COVID, we couldn't think of a better topic than tackling the issue of mental health. I know as a cancer survivor, the first part of the lockdown, when we got into COVID, I quite enjoyed the piece by myself. But as it went on and we had multiple lockdowns, I know my mental health was tested. And recently our support group came back face to face. And whilst a number of our members are still very reticent about coming back face to face, we've engaged using Zoom with our meetings to be able to bring them into the meeting, even though they're not there. But the issue is, when we did talk about the various updates as to where everyone was in their journey with prostate cancer, we did tackle the issue of mental health. And it was quite prominent that each of us in our own way was struggling, if not during COVID, but the COVID lockdowns, but more so in how do we re-engage? How do we get back into our normal rhythm? And even that, even for me, I'm finding rather testing. Today, we've got 2 great speakers in Professor Suzanne Chambers and Ross Henderson. I'll be sort of putting my little bit in from a support group leader's point of view. But I welcome you all. These webinars are for you. I want you to ask any question you want. We're going to get through all your questions. Last year, when we ran our first webinar, one of the feedbacks we got was that in the 2-hour session, everybody that had a question had their question responded to. And that's what we really want to be able to achieve. They are for you, and I encourage you to come forward, put your message in chat, and Kalli, who's our chair today, he'll explain just a little bit of housekeeping on how to do that. But before I hand over to Kalli, bringing something like this together is always a bit of a challenge, but we've had fantastic support from our supporters in Boston Scientific and also the Prostate Cancer Foundation of Australia. Without their support and encouragement, we wouldn't be here today. So without any further ado, again, welcome. Use the session as best you can, and I'll hand over to Dr. Kalli Spencer, who's going to be your chair for today. Kalli.
Thank you so much, Gary, for the wonderful introduction. I really feel honoured to be part of this. It's so nice for me to move from the consultation seat to the other side of the table and sit in the seat of the patient for a while and just sort of imagine what it's like getting that diagnosis, the journey home with that diagnosis and the playing in the back of your head, the time spent at home, either on your own or with family, going for the treatment and sitting in the hospital bed, and then those follow-up PSA tests, waiting to see, is PSA going to be rising, is it going down? and what happens if the cancer returns. So there's so many different steps along this journey where there's emotions that are at play, and I think that's what we really want to explore today, are some of those feelings, and how you can manage with and deal with them. So as I said, it's a privilege to host these webinars and to continue to learn and hear from really not only national experts but international experts in the field. And thank you, Gary, for organizing these regular lunch dates where we can continue the conversation and tackle the different aspects of prostate cancer and how they impact on people's lives. I just wanted to say, if you are triggered by any of the content today, of course, always in an emergency, dial 000, or Lifeline is available 24/7, or do make an appointment at your GP or your health psychologist or psychotherapist. So how's it going to work today? As Gary said, we want you to actively engage with us, and how you're going to do that. You're going to go to the bottom of your screen where the panel is, and you're going to click on the Q&A box or the chat box, but we prefer the Q&A. And there is an option for you to remain anonymous when you ask a question. So if that's what you prefer, please ask your question anonymously. I will then field the question to the appropriate speaker where relevant and when appropriate, and they will provide us with an answer. So you don't really have to turn on your mic, and it just helps to minimize any disruptions this way. So yeah, please keep the questions coming and you will guide our conversation. So also wanted to say, just in between our webinars, there's a wealth of information and resources on the PCFA website. I've also been writing some research blogs. You can Google PCFA research blog or on the most up-to-date treatments and, well, everything related to prostate cancer. So do go and read those. And there's a whole archive going back for many years, so you can keep yourself informed. But anyway, that's enough talking from me. I think it's time to hand over to our speakers. So we have, as Gary mentioned, Professor Suzanne Chambers, who honestly needs no introduction. Both nationally and internationally, she is the go-to person for prostate cancer survivorship. There isn't a scientific journal article that you read where Chambers et al. Is referenced. Guaranteed you can go and see that for yourself. So we are really privileged to have Suzanne joining us today. And she's going to be accompanied by Ross, who wears two hats, one as a psychotherapist, but also the other hat as a survivor of prostate cancer. And he can share his lived experience with us. And Gary will jump in with his decades worth of experience as a support group leader. So let's jump right in. And I'd like to start by talking to Suzanne, who's written a very helpful resource for prostate cancer survivors, well, people along actually any stage of their journey, called Facing the Tiger. So I want to know a little bit about what inspired you to write this book. What can people expect to read in the book and how it can help them? And how can they get a copy for themselves if they really wanted to read it themselves?
Thanks so much, Kalli. And I want to thank you and Gary for inviting me to be here today. And it's lovely to be on this, is it a podium these days? I don't know what you call it when it's virtual, but it's lovely to be here with Ross as well, who I've had the pleasure of knowing for a little while. Look, so my background is that I started my health professional career as a registered nurse, and then I became a health psychologist. And one of the reasons why I became a psychologist, I really think, was because I was working with people with serious illness, and I wanted to understand what was going on for them and how I could better support them. I started working with men with prostate cancer really in the early 90s, when the prostate cancer support group movement was really getting going. And so in many ways, I feel like you're my community. Here I am back with my folks. So it's another aspect of this experience that's just lovely for me. And I spent a lot of time working with guys and their partners, trying to understand their experience as deeply as I could, and testing out with them really different ways that psychologists applied to this experience to see what they thought made sense to them and helped them face the challenges as they moved ahead. And so all the work that I've done has been very much a collaborative effort between myself and the community of men with prostate cancer and their partners that I work with. Now, the first version of Facing the Tiger was actually published in 2013, And the story about that is that I was in New South Wales, in Tamworth, actually, meeting with support group leaders. And I was just saying to them, I've got a lot of health professionals asking me to write down what I do and write a book about this. What do you think I should do? And they said, don't write a book for them, Suzanne, write a book for us. And so I promised to do that in Tamworth over a hamburger. And then I had to absolutely commit to what I said I would do. So I wrote the first version, and that went very well. And I'll just throw in the royalties for that go to the Prostate Cancer Foundation of Australia. So if you support the book, you help yourself and you help the foundation. But then I got some more feedback over the last few years to say I needed to make the book more inclusive. And also I felt from my own point of view that it needed to more deeply address what's going on for men when they feel stuck in their experience, unable to move on. So I did a new version that was launched in February last year. And then finally this year, we produced the health professionals version. So they came last. But I'll just flick back a slide. So just to say that this is the original model that we went on. And I'll just briefly say that I found when I worked with communities and men, they liked this approach of the idea of a prostate cancer diagnosis as a major life stress, because then you could pull out of that the thoughts that drive the unhelpful and distressing feelings, the actions that you can do that might be helpful or unhelpful in the situation you're in, and the physical reactions that you may have to this experience. And what was useful about that as a map was that we could pull those pieces out and do some work on that to try and help men feel more in control in the situation they're in and make plans to move forward. The bit that we've added to that in the more recent version of Facing the Tiger is to bring in the idea of psychological flexibility, which is about being able to pivot to a different way of looking at things, a different perspective when you feel stuck. So that's kind of like the Cook's tour of that. If you want a copy of any of those resources, they're available from Australian Academic Press. You can get them online. And there's the codes for that. But I'm happy to take questions and talk about any of this as we go.
Thanks, Suzanne. The questions already come up from a participant. When I learned of the occurrence, I was in shock and grief. I reacted badly when people told me to think positive. I felt they were invalidating and dismissing what I was going through. I know now how to respond to unsolicited advice, but how do you think I ought to respond?
So I completely get that. And I have lots of people saying to me, it's so unhelpful when people say, just think positive. And dealing with unhelpful thinking is not about thinking positive. That is absolutely not the message to come through. It's about understanding the relationships between your thoughts and your emotions so you can get an insight into how you're feeling. And then this might sound a bit abstract, but working on the relationship with that distressing thought to try and reduce your closeness to it, just in a sense to allow yourself to have a bit of a breather and a break. Look, how do you respond to people when they say that? I'm not sure there's a right answer to that. It depends upon how much the relationship matters to you, I guess. I mean, I would hope that there's less of that coming out. It used to be, I can remember years ago, people would say to me, people give me a pile of books that I'm supposed to read so I can change my attitude, start eating beans, and then I'm going to cure my cancer with positive thinking. And that's just not true. You know, it's just a load of nonsense. I always think what's really important is to understand yourself, understand your experience, and then be able to think of small ways that you can move towards getting yourself in a situation of more ease with where you find yourself.
Thank you for that response. I'm going to move over to Ross and sort of take you back in time, Ross. It has been quite a few years since you received your diagnosis. How did you manage with some of the thoughts that went through your head when you got that diagnosis?
Yeah, thank you, Kalli. It was December 2009 when I got my diagnosis. I remember the day very clearly. It was December the 6th, approximately 8 o'clock at night. It was a Sunday. I remember it well. And I think that the initial shock that I went into about the diagnosis was, the first question I had was, am I going to die? And it was the first question that I asked of my urologist. Sense of panic, a sense of anxiety, a sense of overwhelm were some of what I felt at the time. And I think that it's very easy to get trapped in a lot of negative thoughts about, the diagnosis. So if you're asking me what I found helpful, perhaps the most helpful thing was to have a trusted friend that I could talk to. I remember saying to the urologist at the time, I'd like to sign up for a support group. And he kind of looked a little bit vague. This was back in 2009. And said, well, I don't know about, if you're going to fit into a support group because you're quite young. And a lot of the men are older than you. They're in their 60s, 70s, 80s, and you might not connect. So I felt a sense of aloneness. But what I did know was that talking to a trusted friend really supported me, just in being able to empty myself of those thoughts that I was having. They were catastrophizing thoughts. There was a lot of assumptions being made. It was worst case scenario as opposed to best case scenario. And I was fortunate, I think as a counsellor, I have a lot of counselling friends. So I was able to turn to a friend that had good counselling ears to listen to me non-judgmentally. And I know that what you were just talking about, Kalli, and talking about with Suzanne, one of the most unhelpful things that anybody said to me was just think positive, because I felt quite ashamed hearing that maybe I wasn't being positive enough, and that was my fault, my personality. So on top of already dealing with a cancer diagnosis, I was now feeling ashamed about my responses to that diagnosis. So a trusted friend, and soon getting myself in to see a psychologist within probably about 3 or 4 weeks, were two things that really helped me orient myself to my ways of thinking and to support me through that process.
Yep. We've had a response back to the previous question. I say, why are you saying that to me? Think positive. Then no matter how they reply, I say, because it seems to me that you don't believe I'm able to solve my own problems. Do either of you want to respond to that response? Is it more of a statement?
Do you know, it's such a personal thing how you respond to comments that people make to you that are unhelpful. And I always think, does the relationship matter or not? If the relationship matters, it might be useful to have a conversation where they get some understanding of why saying think positive is unhelpful to you, because there's emotional energy invested in getting into that. And I would agree with Ross, finding someone that you can talk to, who's not going to judge you, who's going to let you give it all airtime, speak it out aloud, what the thoughts are that are worrying you. Because they're like here, they're so close and so painful and so frightening. And if you talk them out, you can just lessen the impact a little and then start to treat them as thoughts rather than facts, to try and, disconnect from those. But it's normal to have those thoughts. I mean, as Ross said, his first thought was, is this going to kill me? Am I going to die? And that's what comes into people's minds. And it's your reaction is quite natural and normal.
Yep. Gary, I wanted you to jump in here and tell me about your experience.
Sure. I was diagnosed going back just on 13 years ago. And like Ross, I can remember vividly where I was. And I was actually in Woolworths scanning my groceries when my urologist rang me on a Saturday and said, can you talk? And I said, sure, thinking that my biopsy that I'd had was going to be fine. And he said, look, we've found something. And I just immediately froze, collected my stuff without paying and started to walk out of Woolworths, and then realised I hadn't paid and went back. But I then went really to ground for a couple of days after that. Like Ross, first thing was, is this going to kill me? But it was really just as a single gay man, just how I'm going to process this, whether you're gay or not, it doesn't matter. It's just, how am I going to deal with this? What does it mean? So like everybody, I went back home, immediately got onto Dr. Google, and just wanted to look at all the downside, really, of having my prostate out. And of course, you discover that, it's going to have potentially an impact on your sexual life, and then reconciling with all of the issues that are perceived to be the downside. I suppose the one thing I did do, which today I'm grateful that I did do it, was I decided that I was going to share it with all my friends, that I wasn't going to just keep it to myself. So I gathered them all together and announced that I had cancer. And their response was brilliant and supportive, but obviously loads of questions, you know, what does it mean? Are you going to be okay? All of those things. But they've been with me right through the journey. And I think now as a support group leader, you know, new members that come in that have been told that they've got prostate cancer and they're going through that process of whether I'm going to watch and wait, whether I'm going to have it removed, all of those choices, which is hard to take in, you know, the first 2 weeks of diagnosis, that you've got all of these choices and pathways. And then you're dealing with varying health professionals, from your urologist, the nurse that assists them and what have you. It's just, who's going to advise me? Who's going to actually tell me what to do? And I think most males, knowing how we respond to the healthcare system, is that we basically go to the doctor when we're sick. We don't go really for annual checkups like we do our car and what have you, which is another whole discussion and probably another whole webinar. But yeah, I think that's the interesting thing now for me as a support group leader with you, Kalli, with our group, and I'm sure for other support group leaders, is, you know, you meet these new members that come in that are looking for answers, and at the same time their whole mental health is just going AWOL. They're all over the shop. And even with those that have partners, whether they be male or female, in many cases the communication between the partner and the patient is difficult, because men do keep things inside a lot more, I think, than what females do. So I'd be interested in what Suzanne and Ross think about what I've just said there.
Ross, do you want to contribute?
Yeah, look, I think that there's definitely some history around and plenty of research about men not being as good in dealing with and expressing their emotions, perhaps as women. I suppose there's some stereotypical part of that, but there is also some truth to it. So I think being able to find a trusted friend that you can talk to, or a counsellor, or a support group, is really essential, because it does give permission to be able to freely talk about your emotions in a way that allows them to be heard. And I did notice a question coming up. Is it the right time to maybe just answer that question?
I was going to drop it in right there. Good timing. Yes, it must be a carer or a relative who's asking, I suppose, as a non-trained psychologist or just a lay person that has to talk to the person that's been diagnosed, their friend or their relative. What sort of things should they do? Should they just listen? Or, you know, how do you resist that urge to jump in and try and help, even though you may not know how to?
Sure. So look, my response to that, yeah, of course, being a counsellor, psychotherapist, is listen. To really be able to be present with whatever their concerns are, their fears are. And it can be really just a helpful process to nod your head and make eye contact and repeat back what you hear them saying as their worries. I think when we try and intervene with a quick fix solution to something, it probably says more about our own need, that we're uncomfortable with the situation, and it might not be meeting the need of the person that has the diagnosis. Listening is, you know, it's not easy. It can raise and be confronting for us to hear the concerns and fears of someone else, particularly as it's often around something to do with death. So I guess what I would encourage, if it was my family or friends, and what I wanted, what was helpful to me, were the people that non-judgmentally were able to just listen to my experience, validate my experience, my emotions, rather than trying to fix something that really was way beyond their comprehension anyway.
Suzanne, would you like to add anything to what Ross said?
Absolutely agree with what Ross has said, and it is true. I mean, there's, you know, I always say, oh, there's research to show that, but there is research to show that men and women do have different coping approaches typically. Now, of course, there's exceptions to that. But generally, men do tend to either take a task-focused problem-solving approach to something, or they'll avoid it. And women are much more emotion-focused, so much more talky. There are exceptions to that, so I throw that in as my caveat as I generalise hugely here. And what this means, of course, when you're diagnosed with cancer is, as Ross has just said, you can't solve that problem. That problem's going to be addressed by a surgeon or a radiation oncologist. So you can feel a bit helpless. And feeling helpless and not being able to take charge really runs in the face of our typical masculine values in this country anyway. So that's a really uncomfortable feeling, and some validating of that sense of angst and frustration and distress is really important. And what that takes is being non-judgmental, sitting and listening, and doing that by being present. And then there's nothing wrong with, when you finally understand the situation, of inviting the person, if there is anything I could do to help, I'd be really happy for you to let me know, because there may well be something you can do to help in a practical sense. I know when members of my family that are close to me have been diagnosed with cancer, I've been very aware that I'm the relative, I'm not the health psychologist when I talk to them. And so my job is not to hop in and try and be a professional. It's to listen, to understand where they're at, and then to say, is there anything that I could do, which might just be cooking a meal or looking after the kids or doing something very practical like that, but giving them a chance to tell me, and then checking back in. Because people will often say, well, everybody was around when I first got diagnosed and gave me lots of attention, but then they all went off on their lives, and then here I am still in this experience. It's hard to feel like anybody notices or cares. So keeping in touch, I think, is important.
Can I just add there? I think that's very important, actually, Suzanne. If I look at my journey, certainly when I told all my friends that I had cancer and then I had my prostate removed and what have you, as time's gone on and I had my regular checkups and so forth, I always thought at the beginning that the further I got away from, having my prostate out and getting these low readings and there's no more cancer there, I always thought it'd get easier over time. And it's actually interesting because I now, sort of the week before I get tested again, my anxiety level goes straight up. And whilst all my friends are there, for all intents and purposes, they consider I'm cured. But I always say, look, I'm a survivor, and it could rear its head again. I know in my family history, cancer was on both sides of the family, so the gene's sitting there. It manifested itself in me in prostate cancer, but it's there, and it is how we live with cancer. And I think that is the big challenge with a lot of men, is how do I live with it now that I've basically done everything I can to manage it and get rid of it or control it. How do I live with it? And it's that survivorship component, I think.
I wanted to change the direction a little bit here and bring in some statistics. They say that almost 20% of men diagnosed with prostate cancer get depression, and up to 30% may develop anxiety. What are some of the things that one should look out? Just ignore the signs in the background. What are some of the signs or symptoms people should look out for? Suzanne.
Okay, I'll jump in. So yes, there are statistics that do suggest, the studies all vary, that, probably around 1 in 5 men will experience some ongoing anxiety or depressive symptoms. And I think, and what are the symptoms of those things? Well, symptoms of, we know what it's like when we feel anxious, right? So we're jumpy, we can't concentrate, we feel fidgety, we might have an upset stomach, we can't get to sleep. There's a whole range of experiences that we might have. And if we're depressed, we just might feel helpless, but we can't see the light at the end of the tunnel. Sleep disturbances again, just feeling down. And of course, for most people, this won't be the first time they've had those sorts of experiences, because life is full of challenges and hurdles, and at different times we do get these depressive symptoms or these anxious experiences. So I think it's really important not to label yourself so much, rather to make sure that if you're not feeling the way you want to feel in yourself, that you're reaching out to others and getting the support. Because cancer doesn't happen in a vacuum. You know, we get to a certain stage in life and we've had a whole heap of experiences and we have a way we approach the world. And then cancer gets lumped into the middle of that. And how complicated it gets often depends upon the life we've led and the things that have happened to us in the past, which is why I rewrote Facing the Tiger to add the Getting Unstuck piece, because it's not always simple. And it doesn't always, you know, some people will have an experience and it'll be resolved and they'll just charge on. But for others, what happens is other issues come up. And I think it's really important that if you're really feeling down in the dumps and really downhearted, that you talk to your GP about that and get an assessment done. Because sometimes there's extra help that's needed. Medication sometimes is needed, getting referred to someone. And you want to make sure that your GP is really in the picture about how you're feeling. That's probably would be my main message about depression and anxiety, but not labeling yourself particularly, just understanding this is a difficult experience and life is full of difficult experiences. Perhaps we can use it as a pivot to say, all right, I'm going to address these issues and make some changes in how I'm living.
I just want to ask you, for those that maybe have never been to a psychologist, sort of what could a person expect out of a typical counseling session? What would happen?
It's a good question, and I'll hand over to Ross because I'd be interested to hear if we say the same things. But, you know, when I meet someone, what I want to find out is their story. I want them to tell me, you know, what's going on for them, what their main worries are, and then to talk to them about what I think, work together on what the story might be and how I might be able to help or how someone else might be able to help. It's really about understanding that person's position and what their worries are, and then working with them in a team to try and help them see another way. But Ross, what do you think?
Thanks, Suzanne. Well, tick, 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 tick to all of that, all the above that you said. I guess, you know, I'm a Gestalt psychotherapist, which probably doesn't mean a lot to many of the people that are listening to this webinar. But my work is highly relational, so rapport building and connecting is a really big part of the first part of the first session, is to really just give the client some space to talk about what brought them to me and why now. That's important, and to hear their experience of what's going on. So that experience might be an emotional experience, it might be a psychological experience, a spiritual experience, a physical experience. And once I've sort of listened to that and maybe made some kind of assessment around it, I'm then really curious about what all of that means to them. And when I start to be able to help them connect the dots between what they're experiencing and the meaning making that they have of those symptoms, it gives us a pathway to work forward. So I'm not particularly goal setting in a first session, but as time goes on, I become more goal setting in my orientation with the client. Yeah.
Suzanne, part of what you do is possibly to create a mental health care plan. Can you tell us a little bit more about that?
Well, if you're going to see a psychologist, you can. This is sort of about practical matters. You can get a Medicare rebate for the fee to see a psychologist, and in order to get that rebate, you need to go to your GP and get a mental health care plan where your GP will do an assessment and write a referral to that psychologist. But I think regardless of whether you want a mental health care plan, it's really good to let your GP know how you're going, because well, hopefully they're not accessible everywhere. I know that. I was reading something in the paper this morning about someone talking about the impossibility of finding one, but your GP is your primary care person who knows your whole picture. And so if you're having some struggles, you want him to know. And I think he'll know about your prostate cancer. He will have referred you to a urologist or to a radiation oncologist. He'll have that information. And this is part of holistic care, about the GP being a person who can coordinate everything for you. I mean, he can do it. The other things a GP can do is, we know exercise medicine is really important for rehabilitation after prostate cancer. And frankly, we should all be practicing good physical activity anyway. A GP can write a chronic disease management plan to get you a Medicare rebate for allied health professionals, which will give support towards seeing an exercise physiologist as well. There's a whole lot of, GP's like a little doorway to a whole lot of things you can get through Medicare, and that's why you really want your GP involved in your care if you're happy to do that.
Can I just jump in? I think you've hit the nail on the head there. Part of the problem is with a lot of men is that you're diagnosed with prostate cancer, and you then, a majority try to put it aside and not engage, and then they do change. They have mental health issues, or they're not coming to terms with it. They're worried about the fact that their sexual practice may change. Am I ever going to be able to enjoy sex again? The point I'm leading to here is you must make that first step, because a lot of men do not know, how do I work the health system? And I think, Suzanne, just what you've been saying there, correct me if I'm wrong, is your first port of call really is your GP. Is that right?
I think so. And Joanna has just asked a question saying, how do you know that the therapist, and there should be a TripAdvisor rating system for therapists, frankly, but, you know, well, hopefully your GP might have some ideas about that. Other trusted places you can call, the Prostate Cancer Foundation of Australia has a helpline with really fabulous nurses. I've met these people, they're so good. Prostate cancer specialist nurses who you can talk through and find out what's available. It is really important to get someone who you can relate to. And, you know, I always say, if you go to someone and you just think they don't get you and you don't like the way they do it, then I advise you to try someone else, because, and it doesn't mean the person was bad, they just might not suit you in particular. But it's a tricky thing, and people often feel nervous. I mean, I know I see prostate cancer patients every week, and the doctors refer them to me, and sometimes I'll answer the phone like they're going, "What's this weird psychologist going to do?" And then after we finish chatting, they're going, "That was actually pretty good, and you're sort of normal, Suzanne." And I think we have ideas about what psychologists or psychotherapists might be like. They're just health professionals who've been trained up particular set of skills and ways of looking at things, who are there to act as a guide.
I think you're right there. Talking to a lot of men, once they've been diagnosed, they either have their opinion of their urologist might be not what you'd hope for, but I think the point you're making there, especially from my experience with availing the services of a clinical psychologist, it took me 3 or 4 before I found someone that I could really talk to, that I felt was listening to me, is probably the best term, that I could relate to. And I think a lot of men, and certainly a lot of men in our group, are afraid to change. Once they've been referred, they don't think that they can ask for another clinical psychologist or whatever the case may be.
Can I?
Oh, sorry, Ross.
No, that's okay, Kalli. I was just, in agreement, and just to further that discussion too, that I think it's so important that you feel safe with whoever you choose as your therapist, or whether that person be a psychologist or a counsellor. And often that's a visceral experience, a feeling of safety within the body. It's where you feel calm, you feel like your nervous system has been not being activated, but rather relaxed. And to not hesitate if it doesn't feel right. A good therapist would recognise that maybe the fit isn't right here and that you need to move on to someone else. So I think that's essential. And it is a hard thing to find a therapist as well. Part of me wants to say, well, our accreditational body, PACFA, has a list of all counsellors, but who wants to go through 1,000 names and not have a clue, what they're like in terms of their personality? So I think a trusted source, such as a GP or a friend that might have some information, or a social worker that works at the hospital or something like that, would be a good way to start. Your microphone.
Sorry. If there was one good thing that came out of COVID, and that was that so many things moved online. Do you two both do online consultations, and what's the merit? Is there benefit to consulting online? Ross, you can begin if you want.
Sure, I'm wearing my board shorts at the moment, so this is one benefit that people don't. That's not true. I'm wearing proper pants. But look, I guess without being silly, the fact that it's so accessible. I mean, you know, you don't have to worry about transport. You don't have to worry about extra costs in getting to a place. It's an accessible thing to do. So I think that speaks volumes. I've opened my business up now, and I allow my clients to choose what works best for them. And I would say probably 50 to 60% of my clients now choose telehealth as an option because it works for them, because it's accessible, it's confidential. You find a private space to be able to do it. So it can work really well.
Yeah, it helps, I suppose, with that stigma. Maybe men don't see it as a weakness going to see a psychologist. You know, at least they can do it without anyone knowing if they wanted to.
Yeah.
Suzanne, what do you say?
I just think it's really convenient. I mean, a large proportion of the men I talk to, I do through the telephone. And in fact, funnily enough, because I've got the technology to do it through, you know, a Zoom type thing, but they actually just prefer the phone. And I think it's more challenging for us because we can't see a person's face, and you know, it's more difficult to know how the person you're chatting to is going. But I think for convenience, I talk to a lot of men and their wives and partners who are from regional areas, and so they just can't get access if they don't have telehealth. I want to mention too, while I think of it, that you know, I mentioned before the Prostate Cancer Foundation of Australia Nurse Helpline. Well, in mid-June, they're launching a counselling service that will be through the telephone. So, so there's more services coming because there is a real need there, and it is difficult to access, and it'll be fabulous confidential service. So watch out for that one in mid-June.
I think that's important. I think that's a great service from the perspective that I just know that it's very hard, even talking to friends, to try and find a clinical psychologist to be able to get into at the moment. COVID has made people more aware that they can experience mental health issues, let alone whether you've got cancer or touched by cancer or not. And people are accessing the services more and more, which I think is brilliant. So
something that people may receive in a consultation is some homework to go and do at home, which I would imagine would be some self-care strategies or self-management strategies for anxiety or depression. What are some of these self-management and self-care strategies?
So the approach that I take is to try and teach the men, help coach the men that I talk to and their partners about what I know about coping strategies that can help. And Facing the Tiger is like the self-management resource that I give to all my patients, so that I'll be chatting to them and we'll be talking through different strategies they can do. And then I can say, if you take this book home with you, and in chapter 10, you'll find this and this, and read it through. You know, I just want to say though, who thinks homework is fun, right? No one thinks. I never thought it was fun when I was at school. I don't think it's fun now. And so in Facing the Tiger, I've tried to really simplify it and make it a bit more normal than what one would normally get. It depends upon what your issue is. I mean, if your main priority, for example, is I want to feel stronger and get back some of my vitality, then the best thing I can probably do is help tee up a meeting with an exercise physiologist to get a proper exercise plan and coach and help the man to make plans for how he's going to do that. If the issue is more about those catastrophizing, worrying thoughts that are driving distress, we might start with, over the next week, I want you to, and this is in the book too, so I want you to think about where are you and what's happening when those thoughts loom largest? What are the emotions that are going with them, just to try and build awareness of that. And then the next step to that will be, let's try and take those thoughts out in our hand and look at them from a distance and think about whether they're realistic or whether they're helpful, and try and see them just as thoughts, not as facts. Because when we have a worrying thought, we react to it as if it's true. If you go to the car park and you can't find your car and you immediately think it's stolen, you'll have a very particular physiological reaction to that than if you just go, oh, I'm on the wrong floor. So, you know, it's a very natural thing that we do. So if it's a thought issue, there are different ways of dealing with thoughts. If it's a stress management, there are strategies for that. And there'll always be little steps that a person can do to start to try and get a way of managing that. And so often starting with really small steps, small as big, and slow as fast. So just taking it slow, trying to do things a little bit differently and mix it up a bit.
Thank you, Suzanne. Ross, did you want to say anything about your activities that can be done at home?
Sure. Well, not all of them can be done at home, but I think I know where you're going with that. The one thing I just wanted to add to what Suzanne was saying, my little motto to my clients is look at your feet, not the mountain, to get them taking those small steps, the little daily steps, whatever they might be. And I think one of the challenges that we have with prostate cancer diagnosis coupled with COVID was that uncertainty got coupled with more uncertainty. And so when people feel that sense of uncertainty and overwhelm, they can feel often out of control. So any little thing that can create some kind of empowerment in their daily life is really, really important. And it can be as simple as making a cup of tea, going for a walk around the block, getting some fresh air, talking to a friend on the phone, or patting your dog, whatever it might be. In dealing with prostate cancer, I think the needs and strategies can sometimes vary between diagnosis, treatment, and aftercare. So that's one point that I'd like to make. And I also, like Suzanne, kind of look at the approaches or the strategies in terms of the emotional, the cognitive, and the physical, but they indeed overlap as well. So, for some people, meditation is a great way of relaxing the thought processes that might be very busy in their mind, but for other people, meditation doesn't work. So I guess the first angle I take is ask them what generally works for you when times are tough. So if I can kind of determine what they're already using and then magnify the use of that, and that can often bring about unique solutions that are relevant to their lives, as opposed to maybe me imposing, well, I think you need to do meditation, I think you need to jog around the block, so that it becomes self-determined rather than me determining it for them. I think the emotional processing, exercise, good nutrition, good sleep patterns are all really important. I think breath work is really important. Relaxation exercises like muscle relaxation is really, really important and can be very helpful. We've already talked a lot about getting support from trusted friends, talking things through. And I also believe that connecting yourself to nature is a really powerful thing. It really helped me, was to go to the ocean and sit and look at the ocean and swim, to immerse myself in water. Again, that helped me. It might not help everybody else. Pet therapy is a wonderful thing. So there'd be some of the things that come to my mind, and also connecting with one's faith or one's spirituality, if that is a support for them, then that can enhance their self-care strategy process too.
Thanks, Ross. Thanks both of you for sharing those strategies. And I'm sure there's a multitude of them, as you say, and obviously you tailor them according to the person's specific needs, which is important. I'm going to jump back to the patients who have been quite vulnerable and shared very specific information about their journeys. And one of them that's come up is, the very common with treatments of prostate cancer, of course, is sexual function or the sexual dysfunction. One person has spoken about that they'll be going for radiotherapy in the next year or so, possibly external beam therapy. And we know that certainly that does affect the nerves and results in erectile dysfunction. And that may return, but it also may be permanent dysfunction. So right now he's fearing impotence more than the metastatic disease. And how can he prepare for the likelihood of permanent impotence? His girlfriend is very understanding, but if she says it's not important, we will have a disagreement. And then there's a second part to that. He's also taking androgen deprivation therapy, which we know the side effect is depression. It causes depression. So there's some very specific issues that come up for some patients. Do you want to just talk to us about this person's experience and how you could tailor your consultation accordingly?
Ross, did you want to go first, or do you want me to go first?
I'm very happy for you to take the lead on that one, Suzanne.
So, it's an excellent question to be raised, and the men that I talk to and their partners this is probably the subject that we spend most time on. And there's lots of different parts to this, because one part is being well informed so that you are aware of what the actual data really is on the likelihood of having erectile function changed. So you understand that, and it's different with different therapies. So it's different. What happens is different with surgery as what happens with radiation oncology, although the data would suggest you end up in the same place a few years down the track, but how it occurs and how problems with erections evolve will change. Now, there are treatments for erectile dysfunction. That's the fancy word that the doctors use, for not being able to get an erection. And it's important to know about those too, so that you know that this is the likelihood. So get the content really clear. This is the likelihood of the sorts of problems that I may experience. And these are the treatments that I can have to address that, so that I can get to a sex life afterwards that is going to be satisfying for me, which may or may not involve penetration. Now, it's easy for me, of course, to say these things, right? You know, as if they're easy to do. And I don't want to give the impression I think that any of this is easy at all. But that's kind of like the physical side of things. But then there's the side of things about how you feel about yourself as a man. And being able to get an erection is part of masculinity. I know I've had men say to me, it's like being able to run and get up in the morning, being able to have an erection. And there's a big sense of loss about that changing. And I think it's really important to not dismiss that and to recognize that. And I'll often spend time with chaps where we just talk about what being a man means to them and all the different parts of being a man and the importance of this part as well. So and there can be some grief and loss in that, and being able to come to the terms of accepting, if I have treatment, this is going to change. And then there's the relationship, which is another thing again. All these things obviously are going to play a role, but the relationship is something else. And I know that I'll often have partners saying, I just want him alive, doesn't bother me whether we have sex again or not. And that's often not particularly comforting for the man who's really worried about it. So it's like working together as a couple to have a conversation, to understand each other's point of view, and working as a team. Because after you have treatment and when you're working on getting your sexual life back to what you want, the closest to what you want, it takes two people to be on the same page about that. And this is not me saying, oh, you must get back to having sex, because I talk to some couples who go, you know what, we weren't having sex anyway. It really doesn't matter to us. And we're not going to do this. I mean, I'll still talk to the man about the importance of penile rehabilitation for health and well-being. But it's perfectly reasonable for couples to make their own decision about how they're going to manage sex after treatment. And I try and you know, it's like for me as a psychologist, it's about being really aware of the painful parts of this, but then also trying to encourage couples to keep close work as a team and try and find a sense of playfulness in how they're going to manage this afterwards. So over to you, Ross.
Yeah, I just wanted to come in before you speak, Ross. We will definitely be going into this in a lot more detail in our July webinar when we have a sexual therapist coming in to talk to us about intimacy and relationships, and how you can change it and get creative and look at intimacy in a new way. So sorry to interrupt there, Ross. What were you going to say?
That's okay. Thank you, Suzanne, too. I thought that was so well explained what you had to say. It's a minefield, this one, because it does touch so many aspects of our masculinity, our sense of identity. I remember I had the privilege to write a chapter for a book that was called Below the Belt, and it was published, I think, back in 2011. And in my chapter, I talked about my fear of the big I, not the big C. Initially, it had been the big C, but it got overtaken by the big I, meaning impotence. And that had huge ramifications for me as a 46-year-old man that was not in a relationship, but having casual sex. And I guess what it brought up for me too is that we also have to bring to the table that for single people, their relationship with sex is different from someone that has a permanent partner. And that can be a very difficult thing to navigate. casual partners want you to function. That's kind of part of the contract. And if you don't feel that you can live up to your part, there's a sense of shame that can ensue. And I remember saying at the time to somebody, and this was very hard for them to hear, and it touches and it connects with what I was saying before about non-judgmental listening. But I made the comment that I'd rather die young and have a good sex life than to die later on in life, to live longer. And it was a very, very hard thing for my friend to hear that. Logically, it didn't make sense to them at all. When I look back at it now, I think logically it doesn't quite make sense to me either. But at the time, it was really, really important that I was putting my sex life right up there in terms of my quality of living and the way that I chose to live my life as a single gay male. So I guess what I'm trying to say is that it does need some navigating. It does need some perhaps expert health from a sexual rehabilitation doctor who I went to see, who put me on Cialis and told me what other options I had available. I've since learnt that you can have sex with casual partners in a playful way. Most people come on board if they know the score. It just takes a little bit more talk and discussion and navigating.
Can I just add in there, my journey, the way I describe it now is about reinvention. I think you've got to know how to, once you've accepted the fact that you've got cancer or had cancer, that you've had whatever treatments you've had, and then knowing if you are going to experience erectile dysfunction or whatever, how do you reinvent yourself? You've got to find a new way to be able to enjoy being with a partner. And I spent a lot of time on that. And I do, even though I've come out the other end from my surgery and so forth, with quite good erectile function, it is still about reinvention. And it's interesting, in talking to various members of our group, just what constitutes good sex. Everyone has a different sort of level on that. Some people, sex is over in 5 to 10 minutes. Others, it can be, in my case, I enjoy the journey. And in actual fact, the ejaculation component to me, even before I was diagnosed with prostate cancer, was always the end of the journey. So, but with others and other men that I've spoken to them, the ejaculation component denoted whether it was good or bad sex. So, it is about reinvention. I don't think, and I encourage people to not view it necessarily as a loss. We're all dealt a certain deck of cards and a hand of cards, but, do the best you can with what you've got. And there are people, that's why support groups are good. And Kalli, one of the things that I know that we're going to touch on later is that as a support group leader, how do you have these discussions with your group in an open and honest way? And mental health, how do you bring this up in a meaningful discussion? Because a lot of men will shy away from the subject in a support group environment. So that's something else we can touch on a little later. But reinvention is the only word that I can describe from my journey.
And can I just say, I love that you call it that, Gary. And, it's such an inspiring way that to the idea, which of course, we can all do at any time in our lives, reinvent ourselves in some ways. Like the way I see it through my lens is it's about having to take stock and then make some decisions about change, which, as Ross has said, little baby steps, and just to try and be playful with those baby steps so that you can just try stuff out and try and pivot in that way. It's a beautiful phrase that you use, Gary.
Is there sorry, Ross, do you want to talk?
Just very quickly, I was just also going to say I love the phrase too. And I think the thing that I've learnt as well, having gone through this, is about the importance of intimacy comes in so many different ways. perhaps over how previously I might have thought about a sexual experience. So I think in some ways that learning is profound for me, and it's changed my view on relationships considerably.
Oh, I want to continue on with this conversation. Do you think is there a difference between how you would handle a younger person and an older person in terms of sexual function?
So I don't think you should make any assumptions about age. Obviously, if you're young, there are different issues you're facing when you've got a diagnosis of cancer, because in your whole life, you don't expect to get cancer when you're young, straight off. You might be still building relationships, still building a career. You might not be as financially secure. You have some expectations about what life is going to be like that get really changed. But mind you, when you're an older person, if you've just decided you're going to now finally do the grey nomad thing, and now you can't go because you've got to have treatment for prostate cancer, that can be, obviously really distressing as well. I certainly talk to men who are quite young and concerned about erectile function and sexual relationships, and I talk to men who are deep into their 70s who feel the same and get quite concerned about how it's going to affect their relationship with their partner. So I think it's really important that we don't make assumptions about age.
Yeah, I totally agree with you. I don't want our participants to think that I'm ignoring them, so I'm going to turn to their questions. I was just trying to keep some sort of flow. And this does feed into what we've been talking about. With anxiety and depression, is it possible there's underreporting of the number of incidents, and that it's actually more prevalent than we thought? And what's actually reported? And then the second part of the question, I know some of cancer patients who refuse to acknowledge that they are actually depressed or have anxiety and seem to have an attitude of, well, if I ignore it, it'll just go away. What are some tips, and this is from a support group leader, of dealing with that? How do you sort of get it out of them and try and get them to recognize that they have a problem and they need to work on it?
Well, I might pick up the underreporting thing, and Ross, let you do the support group conversation. So, look, it is possible that it's underreported. Men don't tend to report distress for a whole range of reasons associated with masculinity and difficult emotions. So that's quite possible. There's certainly also quite a bit of research talking about that men express distress differently. And so men might be more likely to express it physically through, physical symptoms. And there's also work, and you see this in your practice, Ross would see this. And also, not uncommon for men, if they're down, feeling a bit depressed, to be cranky, to get angry and annoyed. And of course, the difficulty that brings is that if you're cranky and angry and annoyed, sometimes that can make people pull away from you, and then it compounds the problem. So I'm not so concerned about prevalence figures. I'm more concerned about understanding how this man I'm talking to is feeling, how his distress is expressing itself in his life, and how we can help with that, how I can work with that man to help with those feelings, and to move them forward.
Kalli, can I get you just to repeat the second part of that question, just so I'm clear in what I'm responding to?
Yes. How some men refuse to acknowledge that they have depression or they have anxiety and have an attitude, if I ignore it, it'll just go away. So these support group leaders are asking for your advice on how do we get men to acknowledge they do have a problem and to deal with it.
Yeah, that's a tricky one. So these men are in the support group already. Look, often depression is a very generic word that can mean different things to different people. So someone that says, I don't have depression, might think of it in terms of, I'm not having suicidal thoughts. But to somebody else, it can mean, I just feel teary and can't get out of bed. I mean, there are whole different ways to experience it. So what I would tend to do if I was a support group leader is tell me what it is that you notice or aware of as you're talking to me right now in your body. I'd get some kind of connection to what the sensations that they were experiencing might be and what they feel about those sensations. And maybe to give voice to some of those sensations. it's a very gestalt way of working. Suzanne, you might have a very different way of working with it to me. I don't think you can force somebody to say, yes, I'm depressed, because it tends to drive them further away into withdrawal. And it's scary. The word depression is a scary word. I remember when I spoke to my urologist and I said, what are the possible impacts on me if I do become impotent and incontinent for the rest of my life? And he said, you're quite likely to become depressed. I had an experience with depression that I did not want to go back to. So I have history around depression, and other people have history around how they know depression or how they've made sense out of that word. So it might be a case that this person might not use the word, but might feel flat, or might feel teary, or might feel hopeless, or might feel that they can't get out of bed. And I'd stay with that and just ask them, well, what's that like for you? It sounds like that's a bit tough. Tell me more about that. Suzanne, I don't know, do you have, that's a tricky one.
So for support groups, I worked with support groups for decades, and it's like a great love affair with support groups because, and I say this often, I've been in support groups where I've seen the most beautiful acts of compassion and empathy that I've ever seen, and done in a very masculine way. So I think what's really important in your support group is just that there is warmth and acceptance for men to be and their partners to be the way they are comfortable with. I used to work very closely with a support group in Brisbane, and they often had quite a formal beginning. They'd have a presentation. It was all, it's like a lecture. And then all the support action happened around the coffee urn. And then when I had to close the building up and I'd say, you guys have got to go, then it moved to the car park. Then finally I have to say, security are going to kick us out. You're going to have to leave now. But no, I truly did. I'm not making that up. But gorgeous men, so good at looking after each other, honestly. But there was no recipe to that. That was just men coming together in a support group, accepting each other, supporting each other, and sharing. Support groups are about shared experience and decreasing loneliness and releasing that tension, learning new coping strategies, and not feeling like you're the only one. And so you do that, I believe, from my observation, you do that through just having an opportunity to be yourself in a group of other men who've had a similar experience and be accepted for who you are.
I think, Kalli, too, one thing I'm aware of to this, we have come a long way in understanding depression and giving it a voice in our community. But there is still some stigma around having depression for males. And so I think if the stigma sometimes can get talked about through other people in the group, that can sometimes be a kind of make it a little less daunting for someone that might be sitting there thinking that they feel a little similarly to that, might take some of the edge off the stigma.
Yeah, and I think, and Suzanne wants to back me up here, there's a wealth of evidence to show that peer-based support is very effective, for coping and managing with prostate cancer or any type of cancer, in fact. So there's definitely value in it, and then the impact on quality of life. I want to go back to our participants, and again, here we have, I think we've naturally segued into the support group segment, so that's perfect. Andrew was, so I mentioned the name, but that's okay. I was diagnosed in 2019 at the age of 58, my brother in 2018 at the age of 60, so it definitely runs in the family. My dad was diagnosed 16 years ago and prostatectomy 3 years later, so strong family history there, and as well as 3 uncles going through the same thing. So despite all the support from family members, I still had nasty thoughts with myself. I decided to join a support group, even though I was the youngest, and that was the best thing I could have done. Being with men going through the same journey, I found uplifting, and the connection has been such that I'm now the group leader. So no one knows what a cancer patient is going through, despite explanations, unless that person has gone through it themselves or going through the same thing. And I think that's definitely why the patient-led support groups are probably the best, having that empathy and those lived experiences. Maybe let's give Gary a turn to sort of jump in on that and tell us what he feels about support groups?
Well, obviously, as a support group leader, I mean, my journey is a little bit the same as the gentleman there. But I think when I was diagnosed, I was desperately looking for, and being single, I was desperately looking for an avenue in which I could find out more, speak to people who had gone through a similar journey or whatever. And fortunately, our support group, the Shine a Light group, was just being developed at that stage. So I was one of the founding members. And Ross was part of that journey as well. I think the interesting thing about support groups, and a lot of people have a fear that, oh, do I really need a support group? And they feel as though there's this overwhelming commitment that if they get in there, they've got to be there all the time or whatever. I mean, with our group, we've had over the time probably well over 100 or more men go through it in that time, and you use a support group for as long as you want to use the support group. We have guys come in when they're diagnosed. We you know, they keep with the support group right through their treatment, and then once they come out the other end a little bit, it's okay. You know, you don't have to attend again, but you always know that the group's there, so that if anything else happens, you've always got that support. Because I've often felt that in many of the talks I've given, whether it be to gay men or whether it be to straight men, you know, the journey's the same. We're biologically the same. It's really around sexual practice and that, where there might be some differentiation to a point, but the loving and the need for support, the need to talk to someone. So in our group sessions, for example, we don't have partners. They can come if they want, but it's always been just really the man that's had the treatment and diagnosed with cancer. And I've found that sometimes, depending on where you are with your partner, that can either inhibit your participation in a support group. So you've got to really work out a little bit about what you want or what your members want, and how you really want to drive the discussion, I think, whether it be around sexual practice. But mental health is something which, look, it's interesting, you know. I mean, we've had, you know, well over into the hundreds of people registering for our webinar series. And, you know, if I look at the numbers that have come in today, it's certainly not everybody. Everybody's registered for a session probably in their own mind, but they're welcome to open up the whole session. But mental health is always one of those things which people think, I don't know what I'm going to say and I don't know how to participate in a mental health discussion. How do I do it? And I think that's the key thing. And I'll touch on this now, Kalli. I mean, we're working on a project at the moment because one of our members during COVID, in the first COVID session, had been diagnosed with prostate cancer, had treatment, and then the cancer recurred right at the beginning of the first lockdown, which was the major lockdown for the whole nation. And I knew this particular individual very, very well, and unfortunately he took his own life in the latter part of that lockdown. It was a profound, it had a profound impact on our whole group, but you always ask yourself, could I have picked up a situation? Could I have registered that there was something wrong or he needed more? But I think mental health, and you know, suicide's not always going to be, you know, the outcome, but it's about to be able to engage in the conversation that I'm not okay. And I need someone to talk to, and I can't make that. It's probably going to be easier with strangers than it's probably going to be with my partner in the first steps. So I think, yeah, support groups are a magnificent tool. Sometimes I don't think we explain them that well. I'd be interested in what others think.
Yes, Suzanne, here's another comment from a support group leader. How can I enable the men in the group to talk about their feelings? Exactly what Gary's saying, or if they're not, how do you pick it up, notice something that's changed? You know, in their group, they don't like having didactic lectures, but they'd rather, and educational talks, they'd rather talk about emotions. His psychologist told him the best thing he can do is model authenticity and emotional integrity. When I talk about my feelings, including dark feelings, the men open up more and start sharing the darker side of their journey. I'm very pleased with this, and I believe there's great healing in talking about feelings. So what are some tips or suggestions for support group leaders and even participants within the group to talk about and deal with emotions in the group setting?
Well, I think that's a wonderful comment. And really that person, that man has explained it, hasn't he? He said, be yourself, be emotionally authentic, connect with people, build safety in the group, where you model that it's okay to talk about difficult feelings, ask people how they're going, acknowledge that it is a stressful experience and that this is difficult. I mean, part of what I do with a lot of the men, well, all of them really, I always make sure I start by saying the reason why you're talking to me is because the diagnosis of prostate cancer is a major life stress and it's difficult. And these are the reasons why it's difficult, so that I'm validating the fact that this is difficult and it is normal to feel upset, and needing to do that because of a tendency towards stoicism that many men will have. I don't think there's one recipe for this. I think it's about creating the right climate. As I sort of said before, sometimes the best sharing will happen around the coffee urn. Sometimes you might get a speaker in who facilitates a conversation. You work with the group you're with and what's comfortable and what's safe for them. But by modelling it, by being authentic, being in the moment with people and making it okay to express these feelings.
He goes on to say groups can be too polite and agreeable sometimes. It's a shared journey in the context of the support group, but we each have our own journey and no two are exactly alike. I believe a disagreement, even a heated disagreement, can clear the air and help us understand where we each stand. And we can respectfully disagree and still be close. I don't try to change people, nor will I allow someone to try to change me.
There's no point trying to change people. It won't work.
Correct. Yep. They want to change themselves, right? Here's another nice suggestion. This support group is rather an exercise group, and they seem to have a very warm and caring attitude. Our members, whilst exercising, often start very important discussions one-on-one. We also meet at a coffee shop and chat there. We cover a wide range of subjects, and often the new members start to trust us and express their issues, and that seems to have a very positive change for the men. Anyone want to speak to that type of support group setup?
I think that's so innovative and creative. I love it. I think when you're oxygenated, you think better, you feel better, your concentration improves, your mood lifts. What a clever strategy. I think it's great.
Yeah, sorry, go on, sir.
There's so much healing just in being with others. Not feeling, there's nothing worse than when you're miserable and it all feels overwhelming and you're on your own. And just to be in the company of people who understand and accept and care for you, there's healing in that. I think we should never underestimate the importance of just being accepted and understood and not being on our own.
Can I just say too, I think we're talking a lot about emotions in support groups, that when we get a diagnosis of prostate cancer, there is a grieving process. A grieving model can actually be quite useful here in understanding that we go through, not necessarily in a linear way, but there are different emotions that happen at different times of the journey. And I think also bringing that in and normalizing that you will feel sometimes angry or sad or frustrated or in shock or whatever it might be, gives permission and allows participants of the group to go, okay, well, that actually has happened to me. Maybe not in that order, but it actually has been partly my experience.
Here's a lovely compliment from our friends across the pond. Malcolm says, what an excellent discussion. I wish we had something similar in New Zealand. But to my knowledge, there isn't any prostate support network that specifically supports gay men in New Zealand. Thank you. And I think to answer to that, the Shine a Light group does offer a hybrid type format. So we do have Zoom. You are able to join the session via Zoom, even if you are in New Zealand, and share with LGBT men and others here in Australia. So you're always welcome. Please don't feel alone. Here's another question from earlier that doesn't necessarily pertain to a support group, but this person asked the psychologist for feedback, and the reply was just to ask me what I thought as a patient, and really the psychologist didn't want to give any feedback and said that the report to the GP was confidential. Do patients have access to their reports? Should they?
Well, I'm sort of, you know what, it's not something I've ever looked looked at, but I'd be surprised that a patient didn't have access to any information that's about them. I write to the doctor after different points with patients that I see, and I tell them what's going in the letter. And if they wanted to see it, I would have no problem sharing it with them, because I'm making a plan with them together. And my purpose in writing to the GP is to make sure he's aware of what this man is struggling with and that he can support us as we go along. And my letters, so the man will always know what I think. And because we're building a hypothesis together about what's going on for you, so typically, as I have a psychological practice, I'll give someone a brief screening assessment for depression and anxiety, physical activity. I will score that. I will share it with them. We'll discuss it together, so that if there's anything on that questionnaire that I'm concerned about, the man and I can discuss what that means and perhaps what we might do about that. We'll be working together to figure out what his main worries are, and perhaps what we could do about that, and making a plan together that he is happy with. And then my role in writing to the doctor is to keep the doctor in the loop.
Ross, did you want to add anything to that?
Nothing to add to that.
Okay. Then something else, and sorry, we'll have to change the tone a bit of our session. Unfortunately, prostate cancer does come back and PSAs rise, and I guess there's all the anxiety that comes with that. And, it doesn't get easier. And I suppose you've still got that almost trauma from the first diagnosis and the first scan and all those biopsies you've done, and now you've got to go through all of that again. So there's so much anxiety around a recurrence. What are some of the coping mechanisms that people can I suppose, work on or use to deal with that anxiety related to fear of recurrence?
Ross, do you want to go first?
Sure. Yeah, I guess I'm thinking of that with two hats on here. My own lived experience of when I have to go and have my PSA done on a yearly basis. And I have to say that after 13 years, I think less and less about it, because my doctor told me that I'm kind of over the 10-year mark and I can take a breather. So I do that. But it is still an anxiety-provoking situation. I find breath work really helpful for me, just monitoring how I'm breathing. Often anxiety has a direct link to breath. So if I'm shallow breathing, not deep breathing, it's going to perhaps make me feel more anxious. And it's very easy when you're vulnerable and you're anxious to think about worst case scenarios. I try and also entertain best case scenarios. That, the last time I went and had my PSA test, everything was fine. There's no evidence to say that there's, going to be a decline or something bad happening this time. So I suppose I try and not try and use a rational approach to it. That's probably all that comes to me on that one. Suzanne?
So I think my experience working with men and my knowledge of the literature as well is that getting a diagnosis of a recurrence of cancer can be more devastating than the initial diagnosis, because of what it means. It means more treatment, and it means more uncertainty about the future. And so it's not that it's different coping strategies, Kalli, it's just that the level of difficulty and burden is, I think, can be higher, and therefore the need for even more support. I often talk with men about saying, while you're getting all these tests done to work out what's going on, let's try and treat the tests as information that are going to help your doctor plan what's going to happen next and what the plan is going to be moving forward. And so there's not one, the coping strategies aren't different. They're kind of the same. It's just the level of burden is I think it's tougher. It's a tough situation to be in, and the treatments are tough. Androgen deprivation therapy is a tough medicine to be on. I mean, it affects mood. It can give you a bit of that brain fog. It affects your muscles and the way your body works. And so this is a situation which I think is really, highly important that a person gets support and also gets advice and assistance to do the things that will help mitigate the side effects of treatment, because what's going to happen is treatments like androgen deprivation therapy that have side effects. It's understanding what's happening, being able to get emotional support and psychological support as you go through this journey, and then recalibrating your expectations about what that's going to be like, and perhaps having to shift your perspective.
One other thing it does is it affects sleep. I know sometimes as a psychologist and psychotherapist, you do also manage with sleep. Any advice there for those whose sleep is affected?
Well, there's tricks for sleep hygiene, and you can do a Google on those. There's straightforward things like don't drink coffee at night, don't exercise before you go to bed, keep regular hours, a whole range of things, and people can find those. Exercise is a really good treatment for helping with sleep. The other thing about sleep is not catastrophizing about sleep. So what often happens is you put your head on the pillow, and of course the brain starts working more busily than it was before. And then on top of that, you're saying, and now I can't sleep. Not sleeping is really bad. So you can get into this thought cycle that just drives it. So there are strategies to unpick that, and just to try and go, you know what, if I don't sleep, I'll sleep more tomorrow night. Try and, get that, decrease that feeling of urgency about the not sleeping. And then doing the other things that we know improve sleep, like keeping regular patterns, exercising, etc.
Can I just add, and I think what you said earlier, Suzanne, is very important. I think the recurrence diagnosis it's a big fear of mine, and I do agree with you that I think it's probably worse than the diagnosis, from the perspective that even with members of our group, it's not to be underestimated. Once they go on go on other therapies, the side effects are the thing that I particularly note as a support group leader in listening to their journey and how it's affecting them. That's where a support group comes into its own, because so many of them have been either on that pathway or whatever, but to be able to talk through just what those effects are and how they are dealing with them, it's just absolutely vital, because I entirely agree. I think a second diagnosis is much harder.
Thanks for sharing, Gary. Just going back a few conversations, psychiatrists can mark reports not to be shared, but I don't know if that means shared with the patient, with other medical professionals, or both. Do either of you know how to respond to that? No. Okay. Sorry. That's all right. Then carrying on with this conversation of recurrence, but also coming to a point where you may decide that you don't want to have further treatments, you're tired of the side effects of ADT, you don't want chemotherapy, and now you need to make a decision that for no further treatment, and possibly, there's a risk of dying, of course. How do you tell your family you decided you're not going to have treatment?
So
tough one.
Everyone can make their own, and it's important you make your own decisions about what you're going to do and how you're going to address the situation that you're in. And what's a good decision? A good decision is one where you know what the pros and cons of your different options are, and then you know what matters most to you, what your values are and what's important to you, and you're able to use those values to guide your decision. It can be helpful to be making that decision with the support of someone who's important to you, so that they're coming along with you on that journey. If you're needing to share that decision with people and that's going to be difficult for you, I guess, what's the answer to that? You could get a health professional, a psychologist or someone to help you with that discussion, or just making a time with people where you're flagging for them in advance that I've got to talk to you about my situation with my cancer, and I just need some quiet time for us to sit down, and this is what we'll be talking about, and to have that conversation in a way where you can share that you've thought through the pros and cons. These are the things that matter to you the most, and it's led you to this decision, and that you're looking for them to support you moving forward. I guess that's what I would do.
Yeah.
You know,
It's a tricky one. It's not something that I've actually experienced personally or as a therapist, but my work would probably be, again, exploring their concerns about telling the family unit what they might be and what those concerns might mean to them. And as a Gestalt therapist, I'd probably be doing some chair work or role play work with giving them some practice to pretend to speak to them, where I can witness that experience and maybe even offer them some feedback as to maybe how they could tweak it a little bit and get their sense of how it went and what they would do differently. Might be one way of approaching it.
Not sure if our participant has a background in psychology, but he likes to refer to the Bowen family systems theory. I'm not here for a good time or a long time, but for a quality time. If my doctor's family and friends don't agree or like it, I'm okay with that. If a man chooses 5 years of sexual function over growing old, likely he knows himself and he is an authentic human being. More of a comment. I don't know if either of you want to respond to that. Or any three of you?
I mean, that resonates with my personal experience that I spoke of earlier, that at that time, that was the meaning that I was making out of my existence, and that I would rather have a shorter lifespan, but with a quality sex life and relational life. You know, that was very hard for people to hear. I've still got friends that tell me to this very day that, you know, I didn't know what to say to you. I wanted to tell you that you're crazy, thinking that way. But, you know, being told I was crazy would just have added to the existing shame that I was already experiencing. So I take that one more as a statement, actually, Kalli.
Yeah.
As I was saying, I think reinvention is the key.
Tim now does confirm he has a B-Psych, so there we go.
Mm-hmm.
Now we have another comment or question. This patient has a grade 5 cancer, so it must be pretty advanced. And he says he copes by working it out alone, and he thinks he's successful at it. But he's just wondering, should he see someone? His wife thinks he should, but he's not sure himself. Any advice?
so do you know? So the question is, why does your wife think you need to see someone? And you know, I do a lot of work with couples where I talk to them about one of the things that's probably most important, if you can do this, if your relationship will allow you to do this, is to work together as a team, where as much as you can be, you're on the same page and you know what's happening with the other person. And I say that because sometimes I will have a partner telling me he doesn't touch me anymore or hug me or talk to me. I feel rejected. I think he doesn't love me anymore, and develops a whole story in her head about what's going on that has nothing to do with what's actually really going on for him. But that's the best that she can derive in the absence of information. And whether it's a male or a female partner, those things can go on. Whereas the guy might be thinking, well, I don't want to burden her and there's no point in me getting close anyway in the current situation. So you can get distance between you through not sharing. And it doesn't mean you have to talk about it all the time. It just means understanding what the other person is, how the other person is managing, and coming to an agreement with each other about how you're going to cope with this situation together. So my suggestion would be, if you can, is just say, tell me why you think I need to talk to someone, and explore that with her. It doesn't have to be an aversive experience to talk to someone. I mean, it might even be nice, and it might even be something that you could do together.
Gary brought this up, and we weren't sure whether we should talk about it or not, but I think we should. What are some of the warning signs that someone may be having suicidal thoughts? What should a support group leader or a friend or a family member look out for, which make you want to be concerned and perhaps do something?
Well, I get concerned if someone is feeling really hopeless, really helpless, and cannot see the light at the end of the tunnel, and just feeling really down about things. And if but I'm talking as a psychologist here, so if I've got someone who's expressing lots of depressive emotions, you know, they're sleep's disturbed, they don't want to get up in the morning, they're having thoughts of suicide, then I will talk to them about that and try and explore that with them, and to say, are they fleeting thoughts? Do you have an intention about this? Do you have a plan? And then work with the person, either as a safety plan that will often involve the general practitioner or the doctor as well. I think that it is important for support group leaders not to think they control the world, and that they can prevent every mishap happening, and to take responsibility for those things. Sometimes really sad, bad things happen, and it's just what happens in life. My advice for a support group leader is to try and notice if someone's feeling really downhearted, and have a conversation with them about where are they getting support from, and trying to make sure that they're connected into support in a way that is acceptable to them.
Ross, do you want to add to this?
I think Suzanne's covered a lot of it. I mean, the key feelings of hopelessness and helplessness are two that I really have an ear out for. Sometimes I listen out for cues of withdrawal, teariness, what goes often with depression. But someone might start using different kind of language, or they might show all of a sudden a mood change that's very different. They go from feeling very down to all of a sudden feeling very good. So a drastic contrast in behaviour might be something I might also just watch out for as a therapist. Look, I'm reminded too that most people don't want to take their life. They want the pain to stop. And I think if I was a support group leader and I identified that there was someone in my group that I was concerned about that might be having suicidal ideation, whether that be implied or whether that be explicit, is to maybe pull them aside if it's not going to happen in the group, and just say, I'm noticing this and I'm just wondering how you're doing. And if you need any added support, who do you see? And I always ensure that they have Lifeline's number, because 131114, I think it's a good number to have always in the phone. That can be of use too. But as Suzanne quite rightly says, is we're not miracle workers either. And sometimes we might miss something or whatever, but we can't do magic. To be observant, to be caring and empathic, to direct and steer someone in the right way, I think maybe of good influence.
Yeah. Obviously, other things like selling off personal belongings, as you say, making a note or things like that, maybe other things to look out for. Again, like I said in the beginning, if anyone's triggered, remember to seek help either through Lifeline, as Ross said, or to book an appointment with your GP or your psychologist. And of course, if you are a support group leader and someone is in immediate danger, then you don't leave their side until you link them to help. I guess that's also an important message. I wanted to make another point. Someone said here about their exercise group. Their mission statement is muscle, mateship, and mood. They've got a slogan for their group, which is quite nice as well. I wanted to, as I see we're running out of questions, I had another question for you. Ross, what do you think, or what is meant by taking a holistic approach to mental health? What does that mean to you?
For me, that just means being able to look at the presenting issue in a global or holistic way, where I take into consideration what's happening in terms of one's physical health, mental health, spiritual health, social health, environmental health, and relational health. So it's just encompassing the big picture, if you like, and breaking that down with the client to say, well, what's happening? How is this diagnosis affecting your relationships? How is it affecting your exercise routine? How is it affecting your sleep patterns? How are you connecting with your spiritual self, and etc. So that's what I mean by looking at it from a holistic way.
And Suzanne, did you want to add anything to holistic?
I would just agree with Ross, and it's remembering, the person's not a blank slate. Someone we've all and thinking about this for ourselves. We have childhood, we have a work life, we have a whole rich tapestry of things that have happened to us, and then cancer comes into our lives, and so all these things interact, and so we're a whole person. We're not just a disease, and so it's and what we're wanting to do is have the best, be living the best way that we can for ourselves. I don't even like the word best, really, because life's full of hardships and good things too, and they coexist, and that's what life is like. So it's doing the best. Like my job and Ross's job is to try and help a person live the way they want to, and pay attention to the things that matter to them.
Tim has again been very vulnerable in sharing his story. He is a survivor until the day it takes me. I have been suicidal in the past, not related to cancer, but cancer has shown me how much I want to live. Quality of life is my only condition, and the only thing I prioritize over the length of my life. So thanks for being vulnerable and opening up. And I think that helps other people, to think and to open up. And these kind of stories, I think, can help other people through. Does anyone want to comment on that comment?
Oh, I think it is wonderful for people to share their thoughts and experiences, and it does make a difference. And it's, and we're all different, and there's no one right or wrong way to do this. But it's a gift for people to be sharing their thoughts, and I thank them for that.
I think we're heading into the last part of our session, and I think we'll start wrapping up. And I just wanted to thank everyone who contributed out of our participants. Thank you so much for joining us today in this first of our webinar series. And these are recorded, and they're going to be available to you. And if you are support group leaders, you can share them through YouTube with your support groups and watch it in one of your sessions and give us feedback, of course. We do value your feedback because that will help us with how we do and how we can improve for our future sessions. So just for some final thoughts, really, and just to reflect on what we've been through today, I'll just go through each speaker again, just to round up and close off. Shall we start with Suzanne? Are you happy just to give us some final thoughts?
Final thoughts. Well, I want to thank everyone for joining in this. This is like a community today, and for being, and again, for sharing their views on all of these things. I would just emphasize that flexibility is really important. Being informed is important. There's no one right or wrong way to do this. What is important is that you understand what's happening to you and you make the decisions that optimize your outcomes from your point of view. It's your perspective that is the valuable one here. Thank you.
Thank you for sharing. Ross, can I hand over to you?
Sure. I'm just thinking of what my main message is as a result of what we've been talking about for the last nearly 2 hours. I guess that when I was first diagnosed with prostate cancer back in 2009, I thought that was it, that my life was pretty much over. And what I've learnt is, in lots of ways, my life has actually changed for the better. So I want to send a message of hope that prostate cancer is a life-changing experience. I don't think there's any other way of looking at that. It does dogleg you into doing different things and thinking different ways and making meaning out of your life in different ways. But I think there's opportunities in the meaning-making process to turn your life into something. Gary used the word reinvention. I like the word rearrangement. I think they kind of mean something similar. That there is hope beyond the prostate cancer diagnosis.
You have another word, Ross, which you haven't mentioned today. You prefer not to be called the survivor, but you call yourself?
The thriver.
The thriver, yes.
Yeah, I like the word thriver because to me it has a different dimension to surviving. That in my own case, in my own personal case, I feel like my life has changed in so many positive ways that I never expected. And that I'm thriving, flourishing is I guess a similar kind of word to use in life. And I think I feel I'm very fortunate. I made some good choices along my journey that helped. I'm very grateful. I don't have any more. Yeah.
Thanks for sharing, Ross. Yeah, I heard something nice the other day. In every challenge, there's an opportunity. And I think that's echoed nicely in what Tim says. He doesn't fight cancer, but he sees cancer as his teacher. And that's true. I, not being a survivor or thriver of cancer, have learned a lot from cancer myself, not just the medical aspect, but so much more, the whole psychosocial aspect, just by being part of this community. So Gary, let's give you a final word, final thoughts about our discussion today.
I think personally, I'll give you two views, personally and as a support group leader. I'm so encouraged by the whole discussion that we've had today and the fact that mental health is now part of my overall personal healthcare plan. Mental health, I think, was not part of the pie for a lot of men. A lot of men think they can soldier on, as Suzanne had been saying, and Ross. But you do have to look after your mental health and your physical health. And I think to be able to actively encourage it from a support group leader perspective, as I said, we're now back to face-to-face meetings with our support group. One of the questions I asked, and Kalli and I were sitting side by side, was after I'd asked everybody to give us an update because we hadn't seen one another face-to-face for 2 years or more, and they give us a physical update of where they're at. I asked everybody, so where are you at from your mental health perspective? And it was like I'd suddenly put, helium into the balloon. I mean, people just, it was like you triggered something and they did want to talk about their mental health because they had in some way thought about their mental health because COVID forced them to. So I'm really encouraged. I think there's a lot of great points that have come out of today's webinar, both from a personal perspective, but also from a support leader's perspective and a health professional's perspective. And actively encourage you, as Kalli said, it's going to be available online through YouTube and show your groups, all your members.
I want to tell you what's still in store for you in our lunchtime conversations that we'll be having through the rest of the year. And Gary did tell us earlier, but just to rehash, in our next session, we'll be talking about erectile dysfunction and sexual dysfunction, particularly the surgical management of that. And we'll have world expert from the United States, Dean Knoll, and locally we'll have Professor Philip Stricker, who's very well known in the cancer community as well, and has one of the largest caseloads of radical prostatectomies, robotic radical prostatectomies. So we're very fortunate to hear from them both at the next session, followed by the session in July, where we'll have, as I said, a sex therapist, where we'll talk a bit more about sexual intimacy, and we'll continue into the themes of well-being, talking about exercise from the exercise physiology specialists from Western Australia, as well as a dietitian. So looking at just how to live with a healthy lifestyle and to complement your survivorship. And then in the session following that, we'll have another expert from the United States speaking. He's a functional urologist, so we'll be speaking about the surgical management and conservative management of patients that have urinary incontinence, either related to their radiation or their surgery, as joined by local expert, Dr. Amanda Chung. And then the last session for the year, Professor Philip Stricker will join us again, as he tells us, as Gary calls it, the Prostate Cancer 101, just going back to sort of the essentials of management of prostate cancer and anything that's new in terms of new research, new treatment approaches. So giving us sort of an update to round out our session and the year. All these sessions are going to be on YouTube, on our YouTube channel. So we have our own Shine a Light channel. We've already got a session that we started last year. You can look up Shine a Light urinary troubles and you'll find a session from last year. And this one will be there as well. And we will send you the link anyway via email so that you have access to that. Are there any final comments or questions from anyone? I know Tim once again said he survived Cyclone Tracy, so believe you me, survival is not less than thriving. Prostatectomy is not a hard thing to get used to. It's a soft thing to get used to. So yeah, I think that brings us to the end of the session, a bit early. But we do hope you have a wonderful Saturday afternoon. And again, we thank you all for taking your time out to join us. And we thank our panelists.
Can I just add, just before we go,
yes.
For those in Australia, of course, today is Federal Election Day. There is still time for you to dash out and make your vote for the nation, and also have a democracy sausage from the Sausage Sizzle as well. So, yeah, I know it's been a bit of a chore for a lot of people because it has been Election Day, but thank you so much indeed for being part of it.
Yep, and I just want to finally thank each of our speakers, honestly, for giving up their time. They do this voluntarily because they love what they do, and you know they see the support and value in these sessions in helping you as a community. So we really, really thank you for your time and your expertise.
Pleasure.
Thank you.
On that note, I think we'll end the session. Thank you, Gary.
Thank you. Thanks.